Good day. This is Dr. John Bennett broadcasting from Miami Beach in Florida. Today we have the pleasure of having Ipcharian, the head of the Nobel Medical Center Department of Surgery in Bharatnagar, Nepal. He's going to talk about skill sets and skull base today. First we'll go around and introduce the panelists. We'll start with Young Hong. Could you please introduce yourself and say hi to Ipe? Hello, Young. Can you hear me, Young? Go ahead.
Yes. Yeah, good.
Okay. Young, where are you from, etc.? Yeah. Can you please introduce yourself?
Introduce myself?
Introduce yourself. Yeah. Who are you?
I'm from China, Shanxi province, at the Taiyuan city.
Okay.
He's the vice director of one of the biggest hospitals in China, John.
Really? Great. It's good to have him here, and he's going to run our first Chinese webinar on cystostomy on the 25th. Okay, Khalid, welcome.
Yeah, thank you. I'm Khalid Ashur. I'm from Egypt. I'm practicing in Saudi Arabia, working in a very busy center. We are dealing with cases of trauma as well, and also vascular neurosurgery cases, especially the emergency cases like aneurysms, microsurgical clipping, and also oncological cases.
Very good.
Thank you.
Right.
Welcome, please. Welcome.
Good
And
to see you.
Duong, unmute yourself. Duong, unmute.
Yeah. Hi, everybody.
Hi.
Hi.
Go ahead, Duong. Where are you from? Where are you practicing?
Yeah, I'm Kian. I'm from Vietnam. I work in the hospital, Saigon Hospital in Hanoi, the capital of Vietnam. I'm very interested in skull-base surgery and cerebrovascular disease. Nice to meet you.
Okay, very good, Duong. Welcome. Dr. Mazhar, how are you? Could you please introduce yourself? Hello, can you hear me, Mazhar? Okay, I don't know if something wrong with his audio. Okay, welcome, Ipe, and it's all yours.
Right. John, I'm sorry, first of all, that we are a bit delayed, but pressing scenario, so I really couldn't. But you know what? I'm going tomorrow to Bangalore, and we are having a World Skull Base meeting there. And I'm going to be leading the anterolateral skull base. I was thinking of televising the whole thing. You know, I thought I would start off with a few things today about anterolateral skull base. We have Wang, who's an expert, and I'm sure the doctor from Egypt is also an expert. So we have a few beginners, experts, so it's a mixed crowd. So I would like to give you a very short introduction as to what exactly is skull base. And we started using it in trauma, but then why skull base? Or is the term actually correct? Skull base term is correct or not? So first thing first, I wanted to ask Sunil Raunia, what do you think about skull base? What is your idea about skull base? Why do you do skull base? For example, let's have a skull here. Okay. So why do you have to do skull base? We're going to talk about anterolateral skull base. Why do you need skull base? You think about it. For example, yesterday, I was operating in India, and I had a CP angle tumor. Patient had a transforaminal herniation, and therefore there was no cisterns at all. Absolutely no cisterns. There were no cisterns at all. So we opened the cerebellomedullary cistern, nothing, dry. And you know what? I had to take off 3 or 4 millimeter of cerebellum. It's a large tumor, so I had to go take it out. To take out a tumor completely, I had to remove lateral cerebellum. Okay, maybe we made an incision, maybe about 3 centimeter, 4 centimeter. And then we took off a little bit of lateral cerebellum, took out the whole tumor. It was a very vascular, probably a 9-10 schwannoma, large one. So there was no cisterns at all. But then on the other hand, I suddenly thought, when I saw that the dry cisterns were dry, I thought it was a bad judgment from me. I could have done a translab here. I could have done a translab. It's a rather easy approach. But then, you know, after 3 aneurysms, I was really tired, and it was the fag end of the day. And I don't want to sit and drill for another 2 or 3 hours doing a translab. And then, you know, it's a huge process, and the setup was rather rural. So I didn't really want, and I mean, it's not my kind of drill bits, and everything is not available. So I continued on with my retromastoid excision and then took it out. But then you see, Yasagil, he started instead of, you must understand, he started trans-Sylvian surgery. All his surgeries, if you see, he was an expert at opening the brain like that, right? So what he did was, he took the frontal lobe, temporal lobe, he opened up, and then he reached all these parts, right? Optic nerve, the pituitary stalk, interpeduncularis cistern, all these things are inside, right? So what he did was, he opened laterally, he went laterally, and he opened the Sylvian fissure. So that is called an intradural oblique unlocking. So you do an intradural oblique unlocking, and then you went in, and then you could reach everything there. Okay. This is called an intradural oblique unlocking. This is not skull base. It's got nothing to do with skull base. It is an intradural oblique unlocking. Now, what is skull base? Skull base is when you take off anterolateral skull base. We are going to talk about anterolateral skull base. There are 2 principles. The brain is like that, right? So the brain is like that. As Yasagil did, we could do an intradural oblique unlocking and go in. Or you could do a sagittal unlocking. How do you do a sagittal unlocking? You have to take this fold off. And what is between this fold? Bone, sphenoid bone. So you have to drill this off, sphenoid bone. Once you drill the sphenoid bone completely, take off the anterior clinoid, you are unlocking sagittally. Okay? And once you unlock sagittally, it's easy for you to get into here. Okay? This is one of the most important principles of skull base. Second principle was discovered by Dolenc. When I was in Dolenc's office in Slovenia, in fact, I was with Roman, who heads the institute at Dolenc's place. So, Roman, we were together in Thailand just 2 weeks back. So Dolenc, I've been with Dolenc. Dolenc is a genius. You know what he did? He also realized that the brain, the frontal and temporal lobes are also like this. Not only like this, it's like this also. So what did he do? He did an axial unlocking. He did a transcavernous, which means he took off the temporal lobe from the cavernous sinus like that. And when he did that, he took off this fold. So it's easier for people to get in there. So the sagittal unlocking and the axial unlocking, this is what is skull base. There is nothing else other than these 2 unlockings. The secret of skull base. You talk about any drilling, you talk about any approach, any peeling, these are the 2 approaches. I'm not talking about endoscopic skull base, but anterolateral skull base, these are the 2 things. So if you have to go into any skull base, for example, Wang does a cystonostomy, what does he do? He has to drill the sphenoid ridge completely. He has to take off. He has to take off the anterior clinoidectomy, okay, if at all, and then he has to peel the temporal lobe laterally. And then what happens? You can get into displace easily once you do the sagittal and the axial unlocking. So this is the principle of anterolateral approaches. This is the principle of Dowling's. This is the principle of Dowling's. This is the principle of any anterolateral skull base approach. Now, having spoken that, what is the skill set you need for anterolateral skull base approach? First thing is, you don't think that only drilling will get you there. First thing first is that you need to know what are you unlocking. For example, if you don't take the temporal bone flush with the base, how are you going to be able to separate the temporal lobe out? Extradually, how can you take the temporal lobe out? It's impossible. So I see people, they say, I did a Dowling's, I did a transcavernous peeling, but I'm not getting space because they have kept the temporal bone like that. So once you do the peeling, you cannot displace the temporal lobe laterally. You cannot peel the temporal lobe laterally. You're just doing a peeling. There's no point in doing the peeling. The whole peeling is for displacing the temporal lobe out. So the skill set starts with the brain. You know, they say the biggest sex organ is the brain. You know, like that, your biggest skill set starts from the brain. You need to have the concept very clear. If you've got to do skull base surgery, if you've got to be an elite, everybody can do skull base. There are some guys who do skull base at a greater level. But if you want to be a real elite skull base surgeon, then you need to understand your concepts very clear. Sagittal unlocking, axial unlocking. How do you do it? Sagittal unlocking, drill everything. And the key to that is the orbitomeningeal band. So please read up about our orbitomeningeal band dissections. We described it in AJNS. There is an article in AJNS. Please read up about the AJNS article where, and I'm also writing a chapter in Luis Borba's new textbook. So I'll be happy to share. I think I've shared the chapter with Wang or my other friends. I have shared this chapter. I'll be happy to share it. Anybody is on WhatsApp with me, I'll be happy to share this chapter. We have completed this chapter and we have submitted this chapter. So how we go under very, very high magnification and dissect the orbitomeningeal band. This is something I teach all over the world. So once we do that, then you will be able to separate the cavernous sinus from the temporal lobe without any bleeding. Dowling's approach, one of the things that is his disadvantage is bleeding, because he's not preserving the true cavernous membrane. He's peeling it off, and this results in bleeding. So you cannot, if you don't want to have bleeding, you need to preserve the pericavernous membrane. And if you want to preserve the pericavernous membrane, the only way you can do it is to dissect the orbitomeningeal band, get into the pericavernous plane, and then dissect it. And I've shown various videos many times. In neurosurgical TV, this is available. So if you can do this dissection, you can do the axial unlocking. Once you do the sagittal and the axial unlocking, then your skill set is to drill. Now, drilling is the most important piece of skill set that a skull base surgeon needs to have. Now, there are many aspects of drilling. Number one is selecting the drill. You need to have a drill which is 80,000 RPM plus. If you have an ENT drill, don't even think about doing fine skull base work. Of course, you can do a lot of skull base work with an ENT drill. I've done it. Okay. But if you want to do fine skull base work, you need 80,000 RPM. Why? Why do you need 80,000 RPM? Why? Because at very high speed, when you touch the bone, you can use the drill like a paintbrush, which means it's very light on your hands. Whole neurosurgery of skull base or vascular is about your lightness of your hand. Okay, how light, how easy your hand moves. If you are tensed up, if you're putting a lot of force on your hands, you cannot do fine neurosurgery. Okay, the best way to figure this out would be doing an anastomosis. Do an anastomosis with very tense hands. It'll be impossible. If you are afraid or if you are tense, anastomosis is impossible. You know what is possible? Taking out a meningioma like that. That's possible if you are tense. but not anastomosis, not fine drilling. Posterior clinoid process drilling, no. You will damage a lot of things if you are very tense, if you are going into the window between the carotid, anterior cerebral artery, and the optic nerve in a 7.5 centimeter depth. If you are very tense, you will damage things. So you need easy hands. So for that, easy hands, the first thing is your drill has to be at very high RPM. So you just touch the bone. I see people drilling and then there is a smell of charring and there is a sound, crrr sound, and then, you know, people irrigate. Wrong technique, very wrong technique. Okay, you can do that on the sphenoid wing with the 8 millimeter drill bit, but if you are drilling skull base, it has to be paintbrush, very light, extremely light on your hands. Okay, so much so, the most important piece of drilling that you need to do is on a raw egg, not boiled egg. On a raw egg, you must be able to first take off the brown of the egg. Okay, if the egg is brown, then you can take off the brown layer of the egg, then the white layer of the egg, and after that, only membrane remains. You should be able to take off. I have shown many times when Wang came here, we were showing this actually. So you can take off just the membrane. There should not be even excoriation on the membrane. If you're using a diamond drill, there will not be even an excoriation on the membrane. Okay, so this is your skill set number 1. Skill set number 2 is to learn to operate in small spaces. How do you develop that? You start operating. You start doing your anastomosis in small, narrower confines. Put a glass over there. Put a glass with a cylinder over your anastomosis and try to operate within it. Put it further and further less, so that you just have enough space to manipulate. This is your second skill set. Now we will go into each detail later on. We will show you videos. And in Bangalore, we have a syllabus. We'll be showing you how we do each of this. We have a CSBC, the Comprehensive Skull Base module, where we are starting it from February onwards, 8 modules, and we'll be showing you each of these, including the anatomy. And once the training centers are established, we'll be having these classes everywhere. So skill set number 1, concept drilling, but the concept first thing first, get your concept clear. Sagittal unlocking, axial unlocking, and of course, after these unlockings, you can use Yasagil's technique and open the entire Sylvian. And you know, things like a basilar, things like a craniopharyngioma, they all become much more easier if you do these unlockings. If you do only one unlocking, it's going to be difficult. But if you do all 3, things become much more easier. Believe me, a skull base surgeon spends a lot of time drilling, but much less time taking out the tumor. Okay, remember that. Now, number 1, drilling. Number 2, operating in narrow, very confined spaces. I would like to stop it here right now. So today's summary would be sagittal unlocking, axial unlocking, oblique intradural unlocking, drilling. Okay. One thing very important to see how the drill turns. If it is clockwise, your paintbrush movement is this. If you're anti-clockwise turn, the drill is in anti-clockwise turn, you have to drill like that. Some people are left-handers, some people are right-handers. So some people, for me, when I'm using the drill in the left hand, I like an anti-clockwise turn. When I'm using the drill in the right hand, I like a clockwise turn. And most important thing, remember, you need to learn to use both your hands. Both your hands simultaneously. How do you do that? I'll show you. Give me a paper. Learn this. Okay, I'm going to show you what. Give me a book or something, guys. Give me a book. Blank page. Okay, learn to do this. All right. Can you see my paper?
Yeah.
Yes.
Yes. Yes.
Learn to do this. Learn to use both your hands at one time. Okay, what I'm going to show you is I'm going to draw with both my hands. Okay, it's very easy. If you learn to do this, you have to be ambidextrous. A skull-based surgeon, good skull-based surgeon is always ambidextrous. Okay. See that? As with both hands. All right?
Mhm.
You need to learn to do this. All right? If you can do this, you're going to use this drill in one hand, the suction in the other hand. You don't have to stop. You don't have to have your assistant, all right, to helping you. You need to be ambidextrous, both hands. Now, you write 1, 2, 3, 4 in one direction. Say, for example, 1, 2, 3, 4, write that. Or you write 1, 2, 3, 4 in another direction. I will show you this. 1, 2, 3, 4. Okay. Mirror. Or like this. Okay. Train yourself. You train yourself to do this. You learn to clip aneurysms with both your hands. You learn to drill with both your hands. Learn to use scissors in both your hands. Okay? And just not enough so that you can cut, but you will be able, just to be able to go into narrow confines and cut. And the kind of advantage that gives you as a skull-based surgeon is immense. So, summary of today's class: sagittal unlocking. First get the concept clear. Sagittal unlocking, axial unlocking, intradural oblique unlocking, drilling, operating in narrow spaces, being ambidextrous. All can be trained. Everything can be trained. Okay? Once we do that, you're going to be world-class skull-based surgeons. Thank you. Any questions?
Yes. Thanks, Ike. Go ahead. Let me quickly introduce Michael Sugru. Ike, I'd like you to meet Michael Sugru from Australia, Oklahoma, and we'll go further into his introduction later. And Naru, can you say hello to Ike? Are you there, Naru? He's a Morocco neurosurgical resident. He'll be joining us. Okay, it's open. Any comments or questions on what Ike has said? Come on, guys. Young or
Yes.
Duong? Uh-oh, Ike, we got a dead audience.
Did I bore them or
I don't know. Come on, you guys. Do you have any questions or comments for Ike? Uh-oh.
John, this is just an introduction, John. So we're going to show videos, whatever we told today. We're going to show unlocking videos. We're going to show, there is no point. So today what I wanted was just an introduction.
Okay.
So in the next part, we're going to show you videos, how we're doing the sagittal unlocking, how you're doing the axial unlocking, how we are drilling. So how do you become ambidextrous? All these videos then we will be showing you.
Okay, do you have a plan? Okay, go ahead.
If there are any questions or suggestions, more than welcome. So from Michael or from the professor from Egypt or Wang, who is an accomplished skull-based surgeon himself, or from anybody, from the doctor from Vietnam. What is your name, the Vietnam doctor? Trung.
Duong? Duong. Go ahead. Unmute Duong. Go ahead.
My name Kian.
Kian. Right.
Yeah, Kian. You can call me that.
Okay.
I found out the way you can both your hand is very interesting. I will learn myself for studying. Yeah, it's very interesting. This is the first time I saw the way you training for yourself. Thank you.
Not at all. My pleasure.
Okay. What do you have a structured skull-based series, right, in February? Can you talk a little bit about that?
It is CSBC. So CSBC is by AMSRS, the Asian Medical Students and Residents Association. It is a society run by Hira. So she is doing this structured skull-based course. So what we are going to do is we're going to have 8 modules, and at the end of it, one evaluation. There is going to be a cadaver course also, for which all the costs, including the stay, will be covered in the registration fee. So they come to us. First 10 participants come to us. First 7 online lectures or something, and then after that they come to us. So we do the cadaver course, and after that one would be evaluation course. After the evaluation, they would be given their certificate.
Okay, so it's an in-person conference, in person.
Yeah. So
like
Hira will be doing
like a workshop.
like a workshop.
Cadaver workshop.
No, but then what I have noticed all over the world is that, I've seen workshops all over the world. In fact, I was part of St. Louis, Missouri, the biggest workshop, skull-based workshop. I was part of that for 4 years. But I found that it is it's very incomplete. I don't know how they're doing it right now. But in 2011 and 2012, when I was part of it, it was incomplete, because if I was a resident, I wouldn't be understanding too much if I just came for 2-3 days, paid $1,500, and then just did something without any concept. Doing something without a concept is a waste. Okay, it's like people just want to get their hand onto the cadaver, and they're not doing anything. They're doing just at that moment, and they're not going to practice it back home. It's very clear. People from Middle East and people from India and all come to St. Louis. They pay $2,000 and just get the hand onto the cadaver, and they're very thrilled by that. That is not the concept that we are doing. We want to make sure whatever you are learning, you go back home and do it. So this is the objective of this course, so that we make them understand in what cases you do it, why should you do it, what is the concepts of opening, and how do you open it. It's not magic, Skull-base is not magic, or skull-base is not only for very, very so-called talented surgeons. There's nobody talented out here. Okay, once you sweat it out, anybody can be talented, and so you don't need to be really old to be wise. All right. So all these things, you need to understand that you need to get the concepts. Even if you are doing anything, whatever you're doing, even if you're driving, if you don't get the concepts right, you're not going to be doing it correctly. So that is the whole point of skull-base. So what I'm doing is I'm going to educate medical students in skull-base, so that they should know skull-base more than what these so-called skull-base surgeons know. I wanted to get them to the concepts, at least the concepts. It's easy, so easy. If you understand those concepts, then you do things because you have an objective. It's like chess. If you don't know what are the you don't know the openings, then you never get into the middle game. If you're not in the middle game, you are never going to get into the end game. So skull-base is precisely like chess. Most of the guys know only some beginnings, some openings, and they know the end game. End game is for them always picking out a tumor. That is not skull-base surgery. If you pick out a petroclival meningioma in one case and you were successful just because you were lucky, that is not skull-base. You are not a skull-base surgeon, mind you. So this is something that has to change. These concepts has to change. If you clip an aneurysm just because you are lucky, you are not a skull-base surgeon. You need to get clearly what are the openings in skull-base, what is the middle game in skull-base, what are the strategies in skull-base, and what is the end game in skull-base. You need to be clearly understanding this. So that is why this course is designed for.
Very good. Excellent. Before we close, I want to introduce Naru from Morocco. He's showing us that this platform can be truly mobile. He's accessing this from his smartphone in his car. Hello, Naru. Can you say hi to Ipe? Can you hear me, Naru?
Yeah. So you're from Morocco?
Yes, here.
Say hi to Elkam Lichi for me. I come to Africa.
Thank you. Thank you, and I appreciate all times your presentation.
Thank you.
Well, he's showing it's truly mobile. I mean, these webinars can be mobile. You can access this from the airport, from your car. And it's
No,
miraculous.
I just finished my shift and I'm going to home.
Oh, okay. Okay, very good. Okay.
Yes.
Okay, very good. I will wrap it up and we'll start with Michael's. Let me just formally wrap this up so I can edit
The
it.
doctor,
So
the doctor
thank you.
from Egypt. I've been in Luxor and I've been in Cairo. Both are beautiful. I've had a cruise in Nile.
Okay.
I was called by the Egyptian Society. I was called there to present on my technique of cystonostomy. So I mean, my first two fellows were from Egypt. So my regards to all the people in Egypt. Thank you for coming. And Wang, my dear friend, I'm seeing you in Beijing very soon.
Well, you're going to hang around for a few minutes to see Michael's lecture? Ipe, you're going to hang around?
I mean, John, I'm afraid I have to go, John. I'm
okay.
Sorry.
Okay, well, say hello to Michael.
Thank you.
And say hello to Michael, and you'll see him again. He's going to China. He's in China.
Michael, John told me a lot about you, and I'm going to catch up with you. We will have a separate Google Hangout session or something. And I'm very interested in your project. I mean, myself, I am into a robotics project with the University of Alicante. So when I was asking about this project, John was talking about you. So let us get down together sometime. Let's have a Google Hangout or something, and let us connect.
Yeah, absolutely. We're doing a lot of interesting work with how to figure out the connectome of individual patients. There's some pretty exciting stuff in the talk. So I'll show it to you when I get a chance.
Great.
Yeah.
Okay. I thank you very much for excellent work.
Sure, John. Sure, John. See you, John.
Okay, Michael.
See you, Mr. Dr. Sheriam. See you later.
Yeah. Okay. I'm gonna introduce you, Mike, just like television. All right. 10, 9, 8, 7, 6, 5, 4. So we edit it later. 6, 4, 3, 2, 1. Hi, this is John Bennett from Miami Beach, Neurosurgical TV. We have another presentation with Michael Sugru, a neurosurgeon originally from Oklahoma, now in Australia, with a project going on in China, and he'll tell us all about that. But first, let us introduce the panelists to Michael. Let's start with Duong. Could you please introduce yourself?
Hello, everybody. My name is Kian. I'm a Vietnamese neurosurgeon. I work in a hospital in the capital of Hanoi. I focus on screw-based surgery and cerebrovascular disease. Nice to meet all of you. Thank you.
Thank you. A frequent participant. Khalid, could you say hello to Michael, please? Unmute yourself there. I know it's tricky. Go ahead. Go ahead.
Okay. This is me, Khalid Ashur. I'm Egyptian neurosurgeon. I'm working in Saudi Arabia. We're fully busy in trauma as usual, and but we are dealing with some cases of emergency vascular surgeries like aneurysm clipping, as well as oncological cases.
Very good. Welcome, Khalid. Yang Hong, could you please introduce yourself to Michael?
I'm from China, and in Taiyuan City. My hospital is Shanxi Danyi Hospital, and my major is mainly in neurotrauma, hemorrhage, and sometimes skull-based and vascular. Nice to meet you, Michael. Thank you.
Good to meet you too.
Yes,
Nice
thank you,
meet
Yang
you.
Hong. Okay, Sunil, could you please introduce yourself? Unmute yourself there, Sunil. Go ahead. Go ahead.
Hello, sir. I'm Sunil. Hope you remember previously we were already introduced, but
Oh yeah,
now,
we go way back, Sunil.
yeah, exactly. So I'm from China. I study here master and PhD program in neurosurgery, and this is my third year. But currently, I don't go to the clinical. I'm doing some lab work right now.
Okay.
Thank you. Mazar, could you please introduce yourself? Are you there? Are you unmuted? Okay, well, how about you, Naru? Could you please introduce yourself to Michael? Go ahead, Naru. Can you hear me? Okay. Okay. Well, okay, Michael, thank you very much for coming, and it's all yours.
Okay, so let me start sharing my screen here.
Okay. Can you, Mike, could you introduce yourself and what you're doing and stuff like that? Or you?
I'm Mike Shagru. I am a neurosurgeon. I do almost all brain tumors. And this is going to summarize some work that I've been doing over the last 6.5 years on a kind of a new field that we're bringing to neurosurgery called connectomics. And so what I'm going to talk about in this talk is a variety of different things in reference to the connectome and our research, what it means for neurosurgeons, and some moving into some really exciting stuff that we're doing on pushing the boundaries forward. So one of the things that we have to really acknowledge is as good as we think we are, we get neurologic problems that we don't understand why we get them. And I would argue that one of the main reasons that we fail in many of these cases is that we use a model like this, where we have really 4 or 5 things in the brain does, and besides that, it's all just this amorphous blob. It's also important to know that the 2 guys who get their name on the brain have been dead for over 150 years, and we haven't updated this model very much. We still teach this in medical school. And I hope to make an argument that this is really an incomplete view of the brain. We can make much better models that predict the deficits that we would cause and help us to avoid them, and that this starts to get into really getting better outcomes. And one of the things that diagram fails to really acknowledge is what neuroscience has been showing over the last 25 years, which is that most higher cognitive functions result from large-scale interactions between widely distributed brain networks. And so in order for us to move forward in operating the supratentorial brain, as much time as we've spent with skull base, in most people's practices is a relatively small portion. As a tumor surgeon, I've taken out many, many skull base meningiomas, but I still do overwhelmingly more gliomas because it's a more common problem to operate in the supratentorial brain. One way that we've begun to tackle this issue of how do we get better maps of the brain and apply them in real life is connectomics. And connectomics is a big data science where we do large-scale mapping of brain connections and try to make sense of them. And in our practice, this really is basically resting state fMRI. And people have made a very big deal about fMRI. They think of it as some kind of magic and that you have to have complex scientists. It is complicated, but nowadays with resting state, this is a scan that can be acquired on almost any MRI in about 8 minutes. Requires no PhD involvement. We do all of the scanning and imaging ourselves and can provide you a tremendous amount of information if you process it correctly. So almost anyone listening to this could be doing this at their hospital. And also diffusion tensor imaging. And together, you can do some very impressive things with this. This was a paper that was published in Nature 2 years ago, and it got a lot of attention, but not, and it was even published in our journals, but people really didn't, I don't think, came up to the correct interpretation of what this paper's significance really was. So let me kind of explain this. So what they did, this is the Human Connectome Project. They scanned over 1,200 people for about 2 days, and they did almost every conceivable type of fMRI you could think of. And they reparcellated the brain. They took Brodmann's 47 areas and redid it to 180 unique areas of the cortex that they claimed were unique. We noticed some very interesting things about this. Let me go back. The first thing that stunned me was the undersurface of the opercular cortex is fundamentally different than the outer surface. So these are different. The second is that there are things sitting in sulci, like for example, this little area here sits in the cleft between the posterior cingulate gyrus and the corpus callosum. We don't pay much attention to that cortex, but it's actually one of the most connected areas of the brain. And there's a lot of things that really got us to thinking that the brain really doesn't care about what we call sulci or gyri. It puts the function wherever it wants to put it. But we thought this was a really valuable tool for a much different reason beyond just its scientific interest. This was an alphabet that we could use to describe how the brain was hooked up. And it's important because we want to be able to talk to people in a way that we're all talking about the same thing in an anatomically correct way, because we think this is the only way that we can preserve higher cognitive function. And so we took this model and we got all of these little areas that were in the connectome project, and we got them through a large amount of work into software that we could use. And we started doing anatomy. And for those of you paying attention, we published this. Eventually this got bigger and bigger. And luckily Nelson Oishiku let us publish this in one issue of Neurosurgery as a supplement, which came out about 2 months ago. And what we did in this tour de force is we first just sat there and figured out where these areas actually were on a real brain. We then did tractography, each area separately, and we did resting state functional connectivity maps. So again, like I said, it's very surprising. There are functional areas that are unique that lie in these little clefts of the insula, underneath surfaces that we don't think about, and in sulci that we don't dissect and look at when we do cortical mapping, which really might explain why we've had some limits to our abilities. Again, when we started doing tractography, we first started out by mapping every area and figuring out where it went, who it talked to. And we made this for every single area, all 180 areas. Obviously, I don't have time to go into all of that. It's about a 500-page long supplement. We then figured out the anatomy of white matter tracts. And we first started with simple tracts. This got a little bit more complicated. And I think when you look at this one, which is the SLF arcuate complex, it's enormous. So when people tell me that they don't think white matter is important, I tell them, what do you think a cut right here does to your function? It inevitably is devastating because of all the areas that now do not talk to each other. So that doesn't mean that no one could ever recover, but I'd put this as one of the worst things we can do messing around in somebody's cerebrum. The next thing we started doing is to try to figure out what these areas were. And we use a technique called meta-analysis, which I know no neurosurgeon is familiar with this. I became familiar with this at a brain mapping meeting. But it's a very powerful technique. So what you can do with meta-analysis is you collect every point that has ever been cited in the fMRI literature, and you map it. And then you can calculate these ALEs, which basically is a three-dimensional Gaussian or bell curve that tells you everywhere in the fMRI literature that has cited that point in space. We have those points, and we can tell what their identities are. And once we know who they were, we can make a map because we know how everything's wired up, more or less. And there's some variability between individuals, but so we try to keep it as general as possible because tackling individual variability is very difficult. But we now have maps of areas like language. So we know that, for not surprisingly, that area 44 and 45 are part of language, but also that this area in the SMA called SFL is also part of language. So I've given this talk lots of different ways over the past year and a half to 2 years since we did all this work. And I really focus a lot of times on the highlights that I think are most beneficial to neurosurgeons to know. And then we'll start talking more specifically and practically about how to actually apply this in the real world. So the first, and I think the most important thing that we've got out of our work in the connectome, and we're not the ones who discovered the frontal aslant tract, but we do think it's extremely important. And it's basically making this angle here. And nobody knew about this tract until a few years ago. It wasn't really known. But what we know now from our studies is what is it actually connecting. So it connects this area here called superior frontal language, and this area 6MA. This is the motor and speech part of the supplementary motor area. And it connects them to area 44 and everything involved in the premotor area. When we started looking at this and we became aware of this, we started doing it on our navigation in every case. And we started avoiding it. And what we found out was that as soon as we started avoiding it, the SMA syndrome stopped happening. It just doesn't happen anymore. It was pretty dramatic. There really wasn't a whole lot of debate in our group. We really stopped ever having it, even when we were operating in the SMA. Another second interesting point is this area here called 55B. Now, I guarantee very few people have ever heard of this. It was discovered in the Connectome project 2 years ago. And it's an area that sits in the back of the middle frontal sulcus. It's this sort of yellow guy right here. And we know that it activates in every single language task. There's not an exception to this. But what's interesting is, even though it sits next to the frontal eye field, The frontal eye field has no connection to the language areas of the temporal lobe, but 55V does. It has its own connections. This is true in everybody. So this little area here has a separate set of connections to the language areas from Broca's area. I've been going back and forth with a friend of mine from residency at UCSF named Eddie Chang, and I told him about this, and it turned out he had electrodes here. So he studied it, and he just published a paper in Cell showing that this is the motor cortex for the larynx. So we went back when he told us that, and we have found patients who cannot talk but otherwise have normal speech, and the tumors are focused right here. So we believe that 55B is a unique language area in the back of the middle frontal gyrus, and we also believe that it can cause neurologic deficits to the language production pathway by not sparing it. And so this is a completely separate pathway of phonemic speech, separate to the Broca's area pathway. I think this is my favorite part of it, which is of connectomics, what we figured out so far, which is the control networks. So if you look at networks, networks have a hierarchy. So the motor network isn't the highest network of the brain. At the top of the hierarchy are two networks. One's called the central executive network, and one's called the default mode network. And these networks alternate. So number one, you're either aligned your function with this one or this one, but not both. And number two is that they're never on at the same time. In fact, in people who they are on at the same time, tend to be schizophrenics. And the more they're on together, the more your schizophrenic symptoms are bad. So the basic model is that when your mind is wandering, when you're living in your internal mental state, this is what's on. And when you're thinking and doing something goal-directed, this is on. And there's a third network called the Salience network, which turns them on and off. So we looked at the anatomy of this. The DMN is a posterior cingulate, anterior cingulate, and parietal network. Interestingly, they don't talk to each other here, but they do talk to each other through the cingulum. The Salience network is an FAT network, so it's a middle cingulate to insula via the FAT. So again, another reason to not cut the FAT. And the central executive network is what we think of as executive function, frontal, pole, and parietal lobe. But what's interestingly, when we started looking at our cases of butterfly gliomas, and we published a paper in the JNS several years ago about this, we were very interested in the DMN because this was the area that when we had patients awake and we were attempting to cross the corpus callosum, the patients would just stop doing what they're doing. They would freeze. And so we knew something was in there. And we initially thought it was the DMN, but we think now it's a little bit more complicated than this. So if you look at these networks, you have your DMN here. This is your internal mental state. The Salience network needs to shut this off. But notice the Salience network and the SMA are together, they're joined. So we think this is an initiation strip by which you get out of neutral gear and go into drive. Now this is the lateral surface. You can see that the anatomy is more complicated here, but we think that this is where the medial frontal syndrome is the destruction of this axis, the command and control axis of the brain. And then if you don't have that, you become abulic or akinetic. So we think that this is an eloquent part of the brain that we should do our best to maintain in continuity. Now there's a lot of people have asked me about this and they said, well, I've seen people have singulectomies where we've done cingulate lesioning. And that's true. There are people who can tolerate a unilateral singulectomy. We don't know how to spot those 30% of people who don't. So I would generally just be aware that this can be a very dangerous endeavor to go operating this part of the brain without paying attention to the anatomy. The next thing is about neglect. And when I first started becoming interested in neglect, I just knew that it was somewhere in the right parietal lobe because that's the only thing we're taught about it in school. So we mapped this out. And what you can see here, for those of you who are students of white matter anatomy, this is the arcuate and SLF. It's very obvious that's what it's doing. So what gets more interesting is you say, what are these areas connecting? And it connects, and I know everyone doesn't know the nomenclature like I do, but just starting here at the bottom, olfactory cortex. This is the analog of speech on the right. Auditory cortex, parietal lobe areas, frontal eye field, somatic motor cortex, and executive network. So what it is that it's none of these areas. It's the wires that get different networks that talk to each other. which is what we've always thought neglect is a failure to bind sensory modalities into a common experience. So now we know that what the real cause of neglect is the white matter. Now, one of the things we thought initially was that there were these so-called dorsal attention network, which I think is actually misnamed now. I think it's actually just your cognitive network. And the ventral attention network, which is actually a right side network. We thought it had to be one of these. But we looked at this and that wasn't true. It's actually not either one of those areas. So it is its own network, and it really is the white matter that binds different areas together. So in short, stay out of the SLF, even on the right. Finally, one of the most important topics that I think in contemporary neurosurgery is what is it in the left temporal pole that causes the cognitive and language deficits that we see in people who've had temporal lobectomies. We know that it happens, they're unpredictable, and they're complicated. And this really comes down to what is the second pathway in language. Everyone agrees that the arcuate and SLF complex on the left side, in most people, is responsible for the phonemic production of speech. No debate. What the debate is what is the other pathway? Hugh Defoe has said the IFOF. A man in the dementia world, Marcel Musalam, has long postulated that it's a combination of the ILF going to the temporal pole via the uncinate to the area 45. And Marco Catani, who's an Italian, who actually was the guy part of the group that discovered the FAT, claims that it's what he calls a temporal fasciculus. And we started looking at this. So this is the temporal polar area called TGD. And there's some interesting things about this slide, so I'm going to go into it a little bit. The first is that if you look at semantic language, it really locates to where we think it does, right here. None of these areas light up, and they're not part of our ALE for semantic language. But there's this little strip by which this area and this area, they fire together. This is a functional connectivity map from resting state. So we know that they're firing at the same time. And interestingly, we have studied this, and there's a white matter bundle that's a set of U fibers that parallels the sulcus, which we've never found that anywhere else in the brain. So it goes along in part with Catani's idea. But here's what's interesting. In addition to the language areas, if you look at the other areas that are activated, it's here, here, and here. So this is the default mode network. So the DMN is part of speech, and probably the temporal pole is related to this. Now, it gets more complicated. If you look at the auditory network that we mapped out, it also has a separate connection to Broca's area, independent of the language areas. Now, what about IFOF? And what about ILF? What are they actually doing? Well, IFOF is a big pathway, and it goes to area 45. And I believe that it has some part in language. But if you look at where this huge pathway is going, you have to look at these guys, V1, V2, V3, V4, V6. These are early visual areas. These aren't areas that tell you what objects are. The only thing that is even close to that is this guy. We don't have any proof that it goes anywhere near area 45. So it can't possibly be providing the object identity to the language areas. It just doesn't fit with any map that we've been able to create. What we think is actually happening are these areas of the frontal lobe, the executive areas, telling these areas what visual system to process, because the visual system is heavily dependent on top-down feedback. So we think that what's really happening is that this is not an occipital frontal pathway taking visual information forward, but a frontal occipital pathway where the frontal lobe is regulating the visual system. So what is it? And I think that the DMN is part of it. I think that the MTG pathway is part of it. But I also think that there's also some more subtle roles in many of the other pathways. So language is complicated, but I think that in short, that we need to start looking at the anatomy of this MTG pathway, and are there ways to avoid that? So getting into the real world, outside of science, how can you apply this in real life? So the first thing about it is actually implementing high-level imaging in your own scanner. And the thing that I think that really has failed to translate as fast as it should is that we think of fMRI as a task. You have to go in there, do a task. There needs to be some kind of expert doing that. And the issue is that a task only tells you what one activity is. Like if you move your hand, it tells you where your hand is activated. The beauty of resting state, it's an 8-minute scan. You don't need it. You just need to make sure it's done correctly. There's no tap. The patient just lays there. You anywhere can do this. We did this in a regular hospital on 1.5T magnet. So as long as your MRI is reasonably new, it will provide a reasonable image. It may not be the best image in the world, but it will be usable for daily life. But the nice thing of resting state is it picks up all the networks at once if you know how to process it. And again, when combined with structural imaging like DTI, again, you do not need radiologists to do this. If you know what you're doing and it doesn't take much work, you can get some very fantastic and very helpful images that you can image guide with. So together, you can show what is activated and how it's connected. And thus, you know what you're about to go in there and operate on. And here's a topic that I think that really needs to get into our field quickly. And this is ICA. So what is ICA? It's a technique called independent component analysis. And I'll just cut through this to the chase of what ICA really does. So in the brain, when you're doing an fMRI, you have all these waveforms going on in different places. So what ICA tries to do is it tries to take this cocktail party. So let's say you have this cocktail party, all these people are talking to each other, and you have microphones all over the room, and they're getting different mixtures of the waveform. What ICA does is it separates the waveforms and figures out that this guy is talking to this guy, and this guy is talking to this guy. Nobody's talking to this guy. And so what people have done with ICA is they know that if you basically do a resting state scan, do ICA on it, you can go and look at pull out all of these networks in most people and show where they're located. And what these are areas that are firing together. So you can see here, this is just a very basic resting state scan. You can see here, here's the dorsal attention network, here's the DMN. All of this was done with about 15 minutes of processing by me, and I'm not a computer expert. So looking through the canonical networks, you can see once you know how to find them, and if you were paying attention earlier, they're very easy to spot once you've done your processing. So you can see DMN, anterior cingulate, posterior cingulate, parietal, central executive, frontal, parietal. Sometimes these networks get split into two. There's a left and right frontal parietal network. The left frontal parietal network is language. But if you look at it, it looks like noise until you realize, okay, there's your Wernicke type area. This is Broca's type area. These are your parietal parts of speech. That's 55B. That's the SMA. Okay. Now, again, there's also a right frontal parietal network. It tends to also have a left side in there, but it's mostly right side. And again, this is more of your neglect and ventral attention network. So why is it worthwhile to get these kind of images and spend the time to put this on your image guidance? Well, the issue with it is that we were always taught, just stay in the tumor when you're doing a glioma. You'll be safe. Well, that's true up to a point. But if you're really trying to get 98, 100% of the radiographic area resected, you're going to run into points where you start coming up against areas that matter. And if you really are honest with yourself, you're going to get neurologic problems that you can't explain. Now, sometimes that's language or something bad. Other times it's a patient who doesn't go back to work. And we don't know right now how to minimize cognitive morbidity other than not operating, which is basically submitting the patient to a faster death. We know that it speeds up their death if you don't remove the low-grade glioma. But we would like to get save as much function, because very few people would say that going from 98 to 100% is so beneficial that it's worth leaving somebody unable to work. And again, these are discussions that we would like to be able to do both, not cause any problems. And so whether we want to think about it or not, you're cutting next to a brain network. Down in the subcortex, there is anatomy. We just don't see it. And so if you don't know what the shape of it is, and you don't have landmarks, then you're basically flying blind in an area where some of the most important parts of the body are located. And we need to get past the idea that the brain didn't evolve parts of the brain as CSF sponges. It's all active. The issue with it is it's all there, whether or not we pay attention to it or not. If you think about the subcortical white matter, this is an analogy I like to describe DTIs and why they're important and why connectomic imaging is important. So the nation of Venice, or Venice, the city of Venice, was an independent country for over 1,000 years. It wasn't because people didn't try to take it over. They tried many times. But the reason they couldn't get there is if you look at here, this is the Italian land mass. Here's Venice. Between the land and the firm land and Venice is this lagoon. And in certain areas, if you don't know what you're doing, you will wreck your boat. So what happened is people would try to invade Venice and they would wreck their boat and that would be the end of the war. That happened many times in history. Nowadays, when you go to Venice, you can basically take these water taxis and they follow these posts all the way to the backside to a way that you would never have thought of. So the Venetian lagoon is the white matter. There's no landmarks and a lot of traps. Having posts doesn't keep you from wrecking. You could wreck into the post. You could go off and ignore them. But it gives you a framework in an amorphous world. And so having landmarks in supratentorial intra-axial brain surgery, particularly for gliomas, when there are no boundaries, is critical. One of the things when we started doing DTIs and doing this sort of work about 6.5 years ago, we found that almost always, wherever certain tracks were terminating, for example, this is the arcuate fasciculus, language was very close. And we published this in neurosurgery about 4 years ago, where the accuracy of this bend is finding language within about a centimeter of that boundary is about 98%. So ignore it at your own risk. We think that it's telling you something pretty good most of the time. There are some limits. And just to convince everyone how accurate it is, that's a speech arrest. Okay. I'm going to put my probe right where that probe was. Right there is the arcuate. This is the tumor. That's the arcuate fasciculus terminating. So they're very accurate. I think that having that is a very valuable way to reduce the morbidity in your patients. So as we began getting more facile with this, we began coming up with the idea of disconnections. So what disconnections mean is that you, instead of thinking yourself going in there with a CUSA and just sucking the tumor out or whatever you do, you're thinking about yourself as dividing between what needs to stay and what doesn't need to stay. And so what this does is it simplifies the surgery into first making a division and second removing it like you would a MET or any other non-eloquent brain tumor. So a couple of divisions, and this just, I can't go into all of them. I have a book that this is from my book that team is about to publish. But basically, for example, the medial frontal disconnection, it has two basic parts. Number one, you need to make sure you don't cut the arcuate fasciculus. And number two, you need to parallel the FAT. You take those down, paralleling those two tracks. And once you've done that, you can do a lobectomy. It doesn't matter. It's disconnected. Now, the question is why, if you look at this diagram, it comes across these fibers of IFOF. And the reason for this is that these tracks are not going anywhere but the tumor that we're removing. You don't want to hit this because it disconnects things that you're not operating on. But here, these are the end fibers, so we don't care so much because it's going to an area of the brain that we've decided we're going to sacrifice in the situation. So here's an example. This is a very big grade 3 oligodendroglioma. You can see here are the tracks. I'll just simplify this because in the interest of time, what we're trying to do is to dodge here. This is the SLF. We want to land in the ventricle paralleling the motor system. You can see that we removed the majority of this tumor. We left this tumor right here. This is the basal forebrain, nucleus basalis. You don't really want to remove that. So we gave radiotherapy and that eventually regressed. This has been about 4.5 years now with no recurrence. So again, this is a very radical surgery, but what you can see is that we maintained certain parts of the connectivity. And again, it really is more of a disconnection than anything. So again, this is a case where the patient's had a biopsy. If you look at the biopsy, it's actually more dangerous than anything we're going to do because it's going through the SLF. Again, this is basically an undisciplined way to think through this case, even to do a biopsy. So we basically, that's the biopsy cut. This is our cut, our craniotomy. We made our disconnections. Again, this was almost 6.5 years ago now. And this patient, my Facebook friend, he's still doing fine. This is my favorite cut, the posterior temporal disconnection. So again, what you're doing, SLF is coming this way. You're making a cut here, and then what you're trying to do is enter the ventricle. One of the things in the temporal lobe you have to realize is that all of the bad stuff is actually lateral to the ventricle. So in the only places in the cerebrum where the superficial stuff is safer, is more dangerous than the deep stuff. So again, you can see here, you're seeing, this is the area, again, in the interest of time, this is where the SLF and arcuate are terminating. So we know language is about here. Our idea is to cut this way, make it as far back as we can get it, so we can access this huge hippocampus tumor. But again, once we've cleared this and they're in the ventricle, there's no fiber tracks going through the ventricle. And so we want to take that angle all the way back. So again, you can see these are the sites. They're right where the tractography said they were. We made sure that we were centered over where our cut is. We made a division and removed all the way back. In fact, I even followed this. You can see I reached all the way behind the thalamus. That's about as far as I could reach. There's a little bit of blood here. But again, a very aggressive resection, but with speech preservation. This guy has basically normal speech or very close. If you look at the parietal side, a parietal disconnection basically goes along this lines. It's kind of the mirror image of the frontal disconnection. You're cutting with the motor system here and the SLF here. So again, the superior parietal lobule approach we've known for a long time is safe, but the reason it's safe is that it takes you medial to these fibers or where the SLF is bending. And so it keeps you out of the white matter. But once you've made these cuts down to the ventricle and to the falx, you can basically do whatever you want. You can even actually go into the posterior cingulate and follow it underneath the motor cortex if that's what you chose to do. So moving on to what I think the future is. So the question is, if everything is active all the time, and people have said, well, there's no such thing as not an eloquent brain. Well, of course there's parts of the brain we can cut into. We know this. We've known this for 100 years. So why can we ever cut the brain? And you have to think about this. But what I think the big thing we think about is that redundancy. We don't need all of the brain. And the reason is because some parts of the brain have parallel pathways that can pick up for it. The other side can compensate. Other networks might be able to compensate. And rehab can change long-term weights of synaptic strength that can help to work around the pathway. So the question is not whether everything's eloquent. We know that we can cut areas. It's how do we figure out what we can't cut? So this is what we're working on now. So what you can do is you can take all the connections of the brain, all the white matter, and make it to a giant graph. And now there's a modality called the virtual brain that you can plug that data in, and it will simulate with a set of differential equations at every site. Turns out that even though we don't know all the microscopic connections of the brain, in many cases it's not that important for the big purpose because they tend to oscillate together. So you can simulate it as what's called the neural field model. And then what we're working on now is coming up with a way to delete parts of that brain and figure out how it changes. So let me show you what it looks like now. This is my brain. And what you're seeing here, this is all simulated data. So what it's doing is it's updating. Every area is linked to the other area. So it's constantly running these equations. So what we think is that eventually we want to be able to remove part of that and see how does this model change. And eventually we want to say, hey, no, if we take this out, this area stops working, and these two areas we know are this, parts of the executive network, and we know from experience and data that this is a bad idea. That is the ultimate weapon in neurosurgery, and we're working towards having that. Obviously, it will take many people's careers to figure out the significance of that, but we hope to have it up and running soon. Finally, if what we're trying to do is save function, part of what we have to understand is that sometimes we are willing to accept a short-term risk under the idea that it will get better. I've never had a patient say they would rather increase the risk of getting a GBM than taking speech therapy for a month. But the answer is, we know that sometimes that doesn't get better. And so one of the things that we sort of got interested in is what's called TMS, or transcranial magnetic stim. It's painless. We have over 119 randomized controlled trials in all sorts of diseases. For depression, it's an approved therapy. And we know that the risk is extremely low and that it's effective for lots of things and that it changes the plasticity of the brain. But we really never found any evidence that was done in neurosurgery patients, not because there was evidence that it was dangerous, but because the people who were doing this were psychiatrists, and they're generally afraid of seizures and things like this, things that we're not so afraid of. So this is what it looks like. The machine basically is hooked up to a generator. This has two electrical coils. They focus a magnetic pulse at a certain part of the brain. It's not very precise, but it's fairly precise. And what we want to try to do is when we're pulling the brain from a tumor, something else, or us, is to figure out, can we force other pathways to do what we want to do? So again, looking at the data, trying to come up with a place that we can basically attack the connectome to get it to do what we want. And sometimes that's stimulating the bad side, but more often we think that the good side is actually the problem because its overactivity prevents activity on the good side or the side that we want to heal. But also it has a lower epilepsy risk. There's no tumor on that side. So again, we've had a lot of interest in treating either bilaterally or just ipsilaterally on the side that's actually not involved. I'll cut through this slide real quick. So far, we've treated over 30 patients. We've had no seizures, and we've actually seen almost everyone we've treated recover, sometimes dramatically. So here's what this looks like. This patient, you can imagine, I didn't do this surgery, but it was referred to me. High-grade glioma, before surgery had aphasia hemiparesis. The DTI said that the tracts were still there, but the patient had no function whatsoever. So in the old days, we would just send them to rehab and hope for the best, but we're actually taking an active role in this now. So what we did, we first did an ICA. So you can see, this is the motor network. This is supposed to cross to both sides, but it doesn't. These are actually separate networks because this has been disconnected. Here's what else is interesting that we've noticed. When you're looking at an injured ICA, these areas here tend to show up. These are areas that we think are being recruited by this area. So this is an opportunity to stimulate and heal them. Now, if you look at her language network, you see something similar. So she has a Broca's area, she has a Wernicke's area, but Wernicke's area is disorganized. Now, they talk to each other physically. Otherwise, they wouldn't synchronize. But we think that we can work on driving that and making it better. And she has very good networks on the other side. That's usually what it looks like. So you see she has a good right frontal parietal network that's a good target. So we first wanted to start out with this continuous paradigm. This shuts down parts of the brain pretty reliably and for about 45 minutes. So what we would do is we'd stimulate her, shut her networks down on the right motor side and in the analog of speech. Then we would have her go to rehab. And then after a couple weeks of that, we did 2 weeks of this, we started treating her on the bad side. So you can see that's the procedure. This is my fellow doing it. And again, it takes about 8 minutes. All's told 15 minutes to set it up. And she's already recovered a substantial amount of function. She can already walk 4 weeks after she started treatment. And has regained much of her speech. So she's not completely normal, but this is a lot better than you would expect given the initial trajectory of this. So again, sometimes you can't find networks, thus you have to know your anatomy. We've had people who didn't have ICA networks that were able to recreate them. So we term this field interventional neurorehabilitation. And this is the idea that neurosurgeons taking an active role in rehabbing the patient because we're the ones who find the deficits. We get to the patients earlier than anybody else. More importantly, we know the anatomy more than anybody. And finally, we're just not afraid of things like seizures, which is really the only risk, and it's extremely low risk. It's like 8 in 100,000. But if it happens, no big deal to us. Whereas a psychiatrist, this is it's the end of their practice. So we look at this and say that this is an exciting new field that we think that we can improve the care of our patients. And again, another area that people could be working on for a long time. Anyway, thanks, guys.
Excellent. Thank you very much, Michael. I'm not a neurosurgeon. All this is new to me. So let's open it up. First, let me introduce you, Michael, to a couple of people that came late. Weil, can you hear me? Weil, could you please introduce yourself to Michael? Hello, Weil, go ahead.
Oh, hello, yeah.
Yes.
Go ahead. Could you please introduce yourself?
Yeah,
where are you from?
Really, I am Weil Rahman. I am a neurosurgical resident. Can you hear me?
Yeah, I can hear you.
Okay, go ahead.
Yeah. I'm Weil Rahman. I am a neurosurgical resident from Sudan. My last year. Really, it's a very fantastic talk. I enjoy it a lot. This field of connectomics will change the field of neurosurgery.
I guess we're breaking up a little bit there, Michael.
Yeah. We that's our goal. Our goal is that
For sure.
Go ahead.
Oh, yes,
go ahead.
that's our goal.
Yeah,
Our goal
neurohabilitation tumors.
Yes.
Well, wow, I don't quite hear you, but I'm glad you could make it here. Thank you. The connection's kind of shaky. I'd like to introduce Rakesh. Rakesh, you say hello to Michael? Unmute yourself there, Rakesh.
Neurosurgery resident from India. It was great to see your Connectome project. Thank you so much.
Okay,
No worries.
Thank you, Rakesh. Okay, KZ, could you please introduce yourself to Michael?
Okay, Zia Kano is a neurosurgeon in Lagos, Nigeria. I had some connection problems and then I had to reconnect and join late, but it's been wonderful. I listened to your lecture sometime online and this is wonderful reconnecting with you. It's very enlightening. And then tumor reflection, we have to pay a lot more attention to these connectomes, and that goes beyond the issues of the corticography that we do that are often on the surface. But I think this will help us a lot more functional work in terms of training the patient, getting the patient back to work. Thank you very much.
No problem. Thank you.
Nigeria, Michael, what do you think of that?
Oh, I want to go to Nigeria a lot. Yeah, I've wanted to go for a long time.
Very good. Hello, Apple. Could you please introduce yourself to Michael? Go ahead, Apple. Go ahead. Go ahead. Go ahead.
Hello.
Hello. Go ahead.
Can you hear me?
Yeah, we can hear you.
Thank you for your invite. I am invited by Yong Hong Wang from China. My name is Liu Yuan from Zhifeng Municipal Hospital. I'm a doctor in charge, neurosurgeon.
Thanks for doing the talk.
Okay, I'm sorry. We're getting
Can
a
you hear
little
me?
interference here. I'm sorry.
Yeah, I can hear you.
Yeah, we can hear you. We can hear you. Go ahead.
No. Oh, okay. I'm graduated from Capital Medical University this year, and I have worked in this hospital for 3 years. During 3 years study, I have interned in Xuanwu Hospital years ago. Vessel anatomosis training. For 4 months that I have some experience and for sharing for you. Sharing with you. To be a new fish in the field of neurosurgery. I want to share the experience to put some idea into surgery. I think preclinical training for micro neurosurgery is very important for young surgeons. New surgeons.
Well, you know, Michael, now might be a good time to tell about your project. Do you want to talk about that now, or you want to just continue the discussion?
Well, yeah. I want to continue.
I'm sorry. Go ahead, Michael.
Oh, sorry. Was someone say something?
Would you like to talk about your project, or you want to talk about?
Oh well, yeah. One of the things we're working on is bringing this technology actually to China. I've been in China 3 times in the last 2 months. And we're working on taking this kind of tech. We have a company that we're working on called Omniscient or Omni China. It's in China, and we're launching it in Hainan right now, but we're planning on eventually taking it nationwide that can provide that kind of the imaging and much better imaging, to be honest, to everybody in China who wants it, where you can basically, get this, you send us the scans and we'll send you back the analytics for more than just neurosurgery, for mental illness and lots of other things that you can, because we now know that mental illness, for example, is really not, depression is not one disease, it's 4 diseases. And that fMRI could tell the difference between them. And that, in fact, these patients don't respond the same. So we know that what we need to be getting on our patients are connectomic images on everybody. It should just be part of how we diagnose patients. And the issue is the technical aspects are very challenging. So what our goal eventually is that, we're not going to try to have everyone become computer scientists. I had to struggle. I taught myself how to program to do this kind of research. But it's not reasonable to ask most people to do that. So what we do is you basically send us the scan and we send you back the data that you want. So that will probably be, we're hoping to have it all ramped up through most of China by the middle of 2020. But we'll probably have it launched by the summer in at least a few cities.
Well, Michael, we could have a separate webcast on exactly what you're doing with the company, etc., to explain to the Chinese neurosurgical community, because that's one community we're trying to grow. Matter of fact, Yonghang, we're going to have our first webinar in Chinese in a couple of weeks, in December 25th. But we're going to continue. We have 3 Chinese neurosurgeons here now, but certainly we hope to reach a lot more Chinese neurosurgeons about many things, as well as projects like yours.
Yeah.
Okay, more comments, questions? Yonghang, you have any questions or comments for Michael?
Well,
go ahead, Sunil. Go ahead.
Thank you, Dr. Michael.
I just
Okay, go ahead. Whoever wants to go first, Yonghang or Sunil.
Yeah, 老许，可以。老许，您可以说。
You first, after you. Thank you, Michael. Thank you, excellent lecture. So this video is very helpful for our brain trauma, so we can more accurate cut the tumor. So very important. So we can know the when we can cut the tumor, and we can make the patient function even more better. Yeah, thank you.
Well, if you're interested in neurotrauma, we think that interventional neurorehabilitation should be what we look at for most of those patients. I mean, it's obvious.
Yeah. Yes.
Wow, that's a lot of patients.
Yeah, well, that's kind of why I decided to make this a major effort of mine, was that it wasn't happening without anybody else. It just was never going to happen through academia. And I looked around and I said, there's a lot of people who should be getting this, and this kind of imaging, this kind of therapy, and we're not getting it. So I decided to just do it.
Okay, interventional neurorehabilitation.
Yeah.
That's going to be a brand new subspecialty, you think?
Well, I don't know if subspecialty. I think it'll just be part of what we do. I mean, who knows? Maybe eventually anything that's popular enough becomes subspecialized.
Wow.
But it's going to be part of being a neurosurgeon, is rehabbing your patients. You're here to do interventions to make their brain better. That's kind of what we do.
Okay, very good. Okay, Apple from Inner Mongolia, China. Wow, I didn't realize that.
Oh,
that's great. Welcome.
Thank you.
I guess Mongolia is part of China now, right? Is it considered part of China?
Of course.
Okay.
In the north of China.
Okay, I'm sorry, I didn't know.
And John.
Yes.
Dr. Liu is my good friend. He worked in Chifeng City.
Oh, really? Okay.
Yeah. She graduate doctor. this year. Next Tuesday, we'll together have a lecture about cystostomy. His topic is microscopic training. Very good.
Oh, good.
Okay. Next Tuesday, we will see together.
Okay, yes. We as I mentioned, Michael, we have a conference in Chinese on Christmas Day.
I'll have to brush up on my Putonghua.
Well, you'll probably be busy.
Okay, of course.
Yeah, a little bit of practice.
Let me see.
So, Wei and Xie, I'll be fine.
Good, very good. Very good.
Okay,
I can teach you one. Just say 你好.
你好.
This is hello. That means like hello, how are you? Like 你好吗?
你好吗? Good. Your Chinese is good.
厉害.
你好.
Oh, okay.
我说我的中文厉害，老师。
老师 ，Hello teacher, yeah.
Yeah. 我是在苏州
Yeah. 苏州 City is very beautiful city.
我这边学习研究也博士学生。
Doctor.
一个博士。
对，这是研究也博士。神经外科。博士。博士。
不是 doctor。
对 doctor。
Doctor， yeah。
挺好。
Yeah, master is a
哇，你普通话真不错哎。
不错。
可以介绍身边的朋友。
Maybe my pronunciation is not good.
Don't worry about Sunil. If everyone in every city in China speaks a different form of Putonghua.
Yeah.
The one hard part is like one word have a 4 meaning here, so it's very difficult to pronounce.
Yeah.
It's very difficult.
Yeah, Michael, I'm talking to Phil right now, so he may come in if you don't mind.
Yeah, sure.
Yeah, okay. Yeah, he's just getting up. He's in Michigan. He's just getting up. Civilian hours, not neurosurgeon hours.
Well, while we're here, does anyone have any other questions, guys?
Yeah, any comments or questions, Duong or Nuru? Michael, you did a lot of glioblastoma multiform surgery, right? You do a lot of that in Oklahoma? You did a lot of that?
I did over 1,000 gliomas while I was there.
Okay, well, we have a Moroccan resident here now that wrote a paper on gliomas. You want to say hello to Michael Nuru? I guess you met him before.
Yeah.
But I didn't realize that you wrote a paper on gliomas. Could you tell Michael about your paper?
Yes. Good morning, Michael. Morning. I'm very happy to meet you, and your presentation is very amazing. I just want to tell you about childhood brainstem glioma. I done one study about review of literature, and I will publish that in so soon. So I just want to know if you have how you manage the brainstem glioma in childhood in your department. Childhood brainstem glioma, GPIG.
Well, here's the thing. The first thing that and again, Charlie Teo is my partner, so we kind of have a strong opinion about it. And I'll tell you our thoughts on the process, which is if it's truly DIPG, then it cannot be removed. But people call DIPG for everything in the brainstem. And most things in the brainstem, at least half of them, are not DIPG. So we've seen things that are gangliogliomas, pilocytics, very focal exophytic grade 2s. where we were able to completely remove some of these with very few problems because they weren't DIPGs. It really comes down to when you talk about inoperable brain tumors, 90% of the time, no one has sat down and thought,
Sorry, Michael, I don't hear you well. I just talk about brainstem glioma and childhood. Brainstem, not just in brain. Brainstem glioma and childhood.
Yes, so that's what I'm saying. So many tumors that get diagnosed as DIPG are not really DIPGs. If it's really a DIPG,
I'm agree with you. Yes.
Yeah. And so we basically pass on a large number of those tumors, but we always look with the thought of trying to get it out if it's possible. And it's sometimes not possible. I mean, there's people we say, I'm sorry, it's infiltrating the whole brainstem. But there's Charlie Teo has some pretty amazing cases. And I mean, I work with him, so I know he's not making this up. Where we've seen some cases where the brainstem was this thick and the rest of it's an exophytic tumor. And it looks like a DIPG, but it's not. And so you really need to look carefully at the images before you give someone, the sorry I can't statement, because it can be removed in many cases. Having said that, you have to always look at it very, very closely in those cases, because people have quit on patients that we've got many years of life for, even when they're eventually die of their disease. And so, the reality is all gliomas are better off removed if possible. There's no exception to that.
Yes, focal brain glioma, brainstem glioma, when it is focal and that can be removed, it is better to remove them, and we can like that we can have a histological diagnosis to know if it is glioblastoma or maybe another tumor can be safe.
Yeah, the answer is there are certainly some people you need to pass on, but yeah, there are glioblastomas that you can get some of them out on. They tend to, what I found in those cases is, as soon as you put your last stitch in, you need to be radiating them because they can grow back very quickly. We'll get a second swing at it. So we have a protocol for if we take something like that out as GBM, as soon as the patient can get to radiation, we get them to radiation.
Yes, radiation, chemotherapy.
That's their only chance. Otherwise, they'll be back very fast, and you'll never get a second chance at it. They'll be hurt too bad.
Okay, but I think that in future, maybe with genetic study, maybe you can search treatment to improve and to fight against this pathology, because when you look the child, it is very. But me, I'm very affected about this pathology in child. But I think that in future, maybe with all progress we have to today.
Well, let me show you something, and this is something else I'm working on. So since we got some time, let me screen share with this.
Sure.
So, can you guys see this?
Yes.
So this is a computer program that we made. Each one of these dots is one gene, and every time that gene talks to another gene, there's a line. So to zoom in and how dense that is, this is zoomed in 30 times. You can see all the lines, all the genes. And glioblastoma has 30 to 100 different genetically different types of clones on average. So I think that my interpretation of that is twofold. Number one, that we're almost certainly going to have to be doing some kind of surgery to get that number down, unless someone figures out a way to treat 100 cancers at once. That's number one. So I don't see that happening in my lifetime, at least. Maybe I'm wrong. The second is what we have is we've taken the whole human genome, and we made that graph of everywhere that the genes interact. And then what we can do is we can take the patient's RNA, we pulse it into that, and it changes that graph everywhere. And then we have a machine that can figure out what parts do we need to cut in that graph. And that is what we're going to be doing with drugs. What drugs do is they break interactions between proteins or eliminate proteins. So what we're trying to do is have machines go in there and figure out in that patient what proteins do we need to get rid of, so we're targeting the right thing. Now, how to do that may be very complicated, but with CRISPR, you can target a lot of things at once, potentially. And that makes a lot of sense to me. But it's a real problem. I mean, when you really get down to the real facts about glioblastoma, it is not messing around. It is a tough, tough problem. So I think that people for a long time have thought that someone's going to go in the lab and find the one drug that will eliminate it. Well, that's not going to happen. If that happens, I will be shocked. It's going to be multiple drugs, and it's going to be big data. And so we've hitched ourselves to big data, where we're trying to make sure that we can handle 350,000 variables, which is what you're going to really take to make sense of that. But you see, it's really, really bad. Sorry, But what we're working on now is that software will hopefully be done by the end of next year or middle of this year. We'll make it available to everyone so people can start running their own data on it. Because at least it's a better way than just guessing, which is what we're doing now. But in the meantime, I tell my residents, keep practicing your gliomas because it's not going away in my lifetime.
Okay, thank you very much.
Yeah, no worries.
So you see, there is hope for treatment of that horrendous cancer.
Well, the hope is going to be big data. I mean, there's a problem that they call wicked problems. And wicked problems are problems where you have many, many variables, but the more important thing is the variables interact with each other. So if you change A, B, then A affects B. B changes in response to A. They change in each other. So like the stock market is a wicked problem, right? No one can predict it because every person there knows what other people are thinking. Everyone's guessing at least. So what ends up happening is there's no stable variable in there. So the issue with it is the first thing when you deal with a wicked problem, when you get down to it, is you start acknowledging you have a wicked problem. It's like acknowledging you have an alcohol problem, right? You have to first address that you have an alcohol problem. And then you can start coming up with ideas on how to solve it. And the way you ultimately solve it is tackle the problem the way it really is. Don't try to pick the variables you like and stuff. You have to have computers that can handle that. And it's only very recently that that's possible, where we can make like that graph. If you open it on your regular computer, it will crash your computer. The spreadsheet is like 15 gigs, and it's an Excel spreadsheet. So it's really, but the issue is computers can do that now. You just have to have the right computers and the right stuff, and you need to work together with people. One of the things that we found is real challenging is that when you sit down and you get neurosurgeons in the room with computer people, they don't speak the same language. And everyone knows AI, big data, this, blockchain. But if you don't know what those words mean and you're a neurosurgeon, you're not going to know what that person can really do for you. And more importantly, they're not going to know what you need them to do for you. So what ends up happening over and over again is someone takes, at Harvard or wherever, not just Harvard specifically, but someplace like that, and they talk to the neurosurgeon, and the neurosurgeon says, hey, why don't you work on this? And this guy goes over there and makes a laser that cuts butter. And so that's great, but we have a knife that cuts butter. Why do we need a solution like that? Oh. And this person is working on something more important.
So Michael, you're going to be the bridge between the tech community and the neurosurgery community?
Well, that's my goal. But I mean, at least in the areas that I think I actually understand. I mean, I'm not an expert at all fields of neurosurgery, but I do know my own field in brain tumors. And I know a lot about the connections of the brain because I've just been studying them for many years now.
Was your decision to go to China based on the fact that they're very advanced in artificial intelligence? Was it based in any reason on that, your decision?
A lot of it. My brother lives in China. Okay. That's some of it. Some of it is just it's a much more dynamic country. I mean, the West is it's very hard to get things done.
Right.
China is much more, let's go and get it done, like the old American way the United States was when I was a kid.
Right.
And it'd be very hard to do something like this in the United States without having a track record.
Right. Right. No, it seems that artificial intelligence is more advanced, and they seem to be doing it more in China than anywhere else in the world. Really.
Well, anything China does a lot, as most of the world.
Yeah, that's true. They got the numbers.
Yeah, for sure.
Okay, Michael, any more comments or questions before we close from anybody? I'm going to hang around. I'm just going to close it officially, but you can hang out here and talk to Mike or whatever. Okay, Mike, thank you. I'll just wrap this up formally, and please stay around, and you can leave when you want. And we're glad you got to talk to some Chinese neurosurgeons, and we hope to grow the Chinese neurosurgery community, which will also be beneficial to your projects too. So thank you, everyone. Thank you, Naru Okizi from Nigeria, and Sunil from China, and Yonghong. Thank you very much. And we'll see you in the next webcast.